We've learned something in the advanced stage 3 patients with a novel approach using neoadjuvant therapy that I think would be a very useful approach for patients who have resectable stage 4 disease, because you optimize the treatment of the disease that you know, and that hopefully the systemic therapy will destroy any or all of the micrometastatic disease that we know these patients have as the source for relapse or new sites of developing distant metastatic disease. So I think that's a very important evolving paradigm that I'm hoping will be studied in a more vigorous way moving forward. And probably the most important thing is the need for better biomarkers, because imagine how good these survival curves would be for the immunotherapeutic agents if we had very good markers to say who is inherently resistant to immunotherapy, or who's likely to acquire resistance to therapy, so we could identify alternative therapies instead of going into a therapy that we know they're not likely to respond to. So maybe those patients, if they're BRAF wild type and they have markers to suggest they're not going to respond to immunotherapy, and they have disease that's resectable, maybe those patients should have surgery as another potential niche for surgery for stage 4 patients. And there may be some other markers or gene expression profiles within the primary tumor. Even in patients who've had metastatic disease, if we go back and look at their primary, we may find signatures that may be useful to predict favorable outcome from a surgical approach. So I think the future challenge is to establish very good biomarkers.